Good morning. I'm Jessica Lovell, and welcome to the Morning Medical Update. 1 in 8 men will be diagnosed with prostate cancer, which means all men need to know how to catch it as early as possible and know the treatments available if they do get that diagnosis. Today, we are meeting a survivor. Once Christopher Carleton was diagnosed, he went in search of an expert surgeon, and that search led him 2,000 miles away from Washington State, all the way to the University of Kansas Cancer Center. Today, we will learn why Chris decided to travel so far for his care, and if this could be a work-related cancer. Plus, what questions men should be asking their physicians. Chris joins us via webcam this morning, all the way from Point Roberts, Washington, where he is the local fire chief. And it's super early where you are, so thank you so much for getting up early.
Good morning. Thank you for having me.
So, Chris, explain kind of where you are in the United States.
Well, Point Roberts, Washington is just below the 49th parallel, and it's the northwest furthest location of the lower 48. You actually have to drive through Canada, British Columbia to get to where I am back home, and that's through 2 border international crossings. One in Blaine, Washington, and the last one in Point Roberts. So every day I have to go through Canada to come and go.
Well, you can't say, not everybody can say that every day. So you're made quite the travel. So we're glad to have you. And I know you're on call right now, which means that you may have to run at any moment. So we want to get started. Joining us for this conversation is Chris's surgeon, Dr. Will Parker. He is a urologic oncologist at the University of Kansas Cancer Center. And we like to point out that urology, big umbrella, but you deal exclusively with prostate cancer.
That's right.
How are you?
I'm doing well. Thanks for having me.
Good. Good to see Chris, I would imagine,
up
yes,
early. Absolutely. Yes.
Yeah. So, Chris, let's start with your diagnosis, if we can. How did you find out that you had prostate cancer?
Sure. This started a number of years ago. My PSA had been rising, and actually, my PCP here in Washington actually missed it for about 2 years. They didn't consider my PSA to be high because it was around 1 or 2. The national average is around 4, as I understand. And last July of 2023, my PSA went over 5. And that's when we decided to take a further look. Up to that point, it was in the high 2s, mid 3s, and that was actually probably double what it should have been for my age at the time.
So, Dr. Parker, is it unusual for a doctor to miss that for a couple of years?
I mean, unfortunately, towards Chris's point, most labs use this reference standard of 4 to say, is it abnormal or not abnormal? And the reality is 4 may be a normal level for somebody about 65, but when you're less than 65, 4 is actually an elevated PSA. And
explain PSA, too.
So PSA, it's a blood test. It's a screening tool for prostate cancer. It's a test that we use to really assess prostate health. And as the PSA rises, it reflects a greater risk that prostate cancer could be present.
So, Chris, were you always checking your PSA? You said you had kind of kept an eye on it, but was it something just that you were familiar with? And were you feeling any symptoms or anything?
Well, of course, I've been tracking my PSA for the better part of a decade. And, symptoms, I really didn't have symptoms at the time. I think men start to have maybe a little difficulty with urination as the prostate may get bigger. But for me, I really had minor symptoms. My biggest track was following my PSA.
As PSA rises, are there symptoms that may come up that people need to be on the lookout for?
Typically with prostate cancer, no. So most symptoms when it comes to men who are at risk for prostate cancer are just related to growth of the prostate. As we age as men, prostates get bigger, so you start to see slowed urinary stream, trouble urinating, but that's unrelated to prostate cancer. For the vast majority of men, it really is relying on the PSA as the trigger to say there may be a problem, there may be a cancer that's driving this.
So when a patient comes to you, are they usually someone who's been tracking their PSA for quite a long time, like Chris, for a decade, or are they sometimes taken off guard by that and said, I didn't even know to look or ask or get it tested?
Both.
Okay.
So I do see men like Chris who are very strong advocates for their health care. They monitor their PSA, they stay on top of it, and they're driving a lot of the decision making, which is great because it leads to early detection and early treatment. And then I have other men who they go to a health fair or they, some random event happens where they suddenly get a PSA that they had not been receiving and the PSA is high.
So, Chris, where did you seek care before?
So initially, obviously in Bellingham, Washington was where my primary care is at. And from there, my pathway was kind of maybe abnormal for some, but I was able to get an MRI very quickly. That was one of the directions my primary care took. I could go see a urologist or I could get an MRI. I chose the MRI. The MRI showed my lesion in my prostate. From there, I actually got a clarified PET scan even before my biopsy, just to see if I had any metastasis. And then I got my biopsy done down at University of Washington here in Seattle.
And did you go to Mayo at some point?
I did. So from the University of Washington, again, a little bit disappointing. It was the surgeon there became actually the least qualified individual. And the University of Washington, Seattle, Harborview is a very well-known medical facility, and that was very disappointing. But from there, I went to Rochester, Minnesota. I flew out to Mayo to meet with Igor Frank. And then my third hospital that I was going to be looking at was University of Kansas KU Medical.
So how did you hear about Dr. Parker? What kind of research did you do on the guy?
So I was somewhat lucky. I lived in Kansas City for better part, a little over a decade. That's where I started my fire service career, was with Kansas City, Missouri Fire Department in 1994, and went through college at the University of Missouri, Kansas City, UMKC there, and had a lot of friends. Actually, one of my cousins, Dr. Parker, met him. My cousin Jeff actually had his prostate removed at University of Kansas, and I think that was right around the time the Da Vinci came out. If I'm not mistaken, around 2014. So he was able to give me a lot of good information about the University of Kansas. And then Dr. Parker came on my radar. And of course, you do background checks and everything else, as much information that you can find on a physician. I got the appointment, and the first meeting was incredible.
So it's like 6 degrees to Dr. Parker, right? I love that you did the research. A lot of people don't do that. I just want to back up. Should patients be asking for those scans and MRIs? He said he kind of took a different path. Is that something that he pushed for, or is that something that the doctor said, hey, we got to get you in for that?
I would say that is a very different path. Most of the time, those scans are hard to get approved through insurance without a diagnosis first. The MRI, a little less so, but the PET scan, the PYLARIFY PET scan, most insurers won't cover if it's done before the diagnosis. But along the way, a lot of men do need those tests in order to ensure that we're appropriately treating them, that we understand the extent of the problem that we're facing.
So what do you make, though, of Chris kind of going and continuing to search answers? He ends up finding you, but is it typical for someone to be, even just going out of state, more than one spot, to really make sure that they're finding the right person?
I mean, certainly I see it all ways, right? I see men who come and maybe I make their diagnosis and they stay with me and they don't go seek other opinions. And then I see men like Chris who do seek out and search knowledge and second opinions, and I value that. I enjoy it. Now, that may sound a little self-fulfilling, right? Because he came and saw me, and I love our interaction. But I do, I think it's so refreshing when somebody takes, their health care very seriously and really takes ownership of making sure they understand what they need and seek out what fits well for them. So
what did you make of Chris when you first met him? What did you think? And then how did you go about, his treatment path?
I mean, it was a great meeting. Obviously, he came in incredibly well informed, which is wonderful because then we were able to really speak kind of brass tacks, right? We were able to dive right in. While I love educating men, I really do. Sometimes in those initial conversations, we're spending a lot of time coming up with a common language, right? What is the diagnosis? What are we, what are the options? How do we approach this? And then it gets a little bit harder to get in some of the nuance, at least at those first visits, about what can we do. With Chris, it was easy. We could dive right in and we could go into really nuanced discussions about how could we approach this, what could we offer him based on his specific cancer. So
let's talk about that diagnosis. Explain more about it. And are there different types of prostate cancers?
So there are some different types of prostate cancer, but by and large, all prostate cancers are the same thing. It's an adenocarcinoma, a glandular cancer that exists on a continuum. So this is where really the nuance comes in. Prostate cancer is a graded disease where it increases in aggressiveness And so that grading system is what helps us understand what are the appropriate treatment options that we have for somebody. Is it appropriate to monitor, or do we need to do something more invasive like surgery or radiation?
Well, that was my next question. If this was the type that could be on an active surveillance, or no, we got to jump right in.
So this was not on the we could do active surveillance. So there are some firm guidelines about when you've kind of crossed the threshold to say now it's time to intervene. For Chris, unfortunately, at the time of the diagnosis, we had already crossed that threshold. Now, not terribly far beyond that threshold, but far enough that we needed to do something.
So there's options.
Yes.
He chose surgery. What made him a good candidate for surgery?
Well, I mean, obviously, he's incredibly healthy. Surgery, uniquely when it comes to decision-making in prostate cancer, because you have two choices, surgery and radiation. Mm-hmm. One, surgery does carry some physiologic risk, right? I've got to put somebody through a physiologic stress. Surgery is a 3-hour operation. That's a lot of time to be under anesthesia. And so Chris, being incredibly healthy and fit, made him a great candidate for surgery if that is the route that he ultimately wanted to go.
So Chris, was that going to be your go-to option? Did you consider radiation?
No, I didn't even really consider radiation. Surgery was the direction I wanted to take. I wanted to get my prostate out, get rid of the cancer, take the road that gave me the best prognosis for a long life.
So for those who may have to go down the same path and make that same decision, tell us about the surgery experience, your recovery. When were you able to get back to work?
So it was really minimal, actually. Right now, it's like it never happened. And, I was very comfortable with the Kansas City area. My sister actually was a nurse at KU for a number of years and lives out in Olathe. So I was able to stay with my sister during the surgery and the recovery. And my family was there. So that was wonderful. My wife was able to come in from Washington as well. And the day, I guess, or a couple days before, I threw out a name to Dr. Parker, and that was Reg Dusing, which I believe was a professor emeritus from KU. And people wonder, well, he wondered how I met Reg, and it was actually through a person in Point Roberts, my hometown, and below the 49th parallel there, that actually served with Reg overseas. And he called when he found out that I had prostate cancer and asked me to reach out to Reg. And I did, and Reg and I met up for lunch. And Dr. Parker was very surprised that I knew Reg, and that was a pretty interesting conversation, but a wonderful man. So the day of the surgery, obviously the facilities are incredible with KU and the University of Kansas, and I was welcomed with open arms, and I was a little emotional that day, as anybody could imagine. And I have a big belief in God and my Christianity. I was raised Catholic, but they let me wear my rosary, which may not be protocol. So sorry if it wasn't protocol, but it was wooden, and they just taped it to my arm, and that made me very, very calm. Emotional. They made me very comfortable going into surgery. I woke up, was not in pain, and again, the facilities were incredible. I stayed overnight. The next day, I was discharged. I went to my sister's house for the next week, was able to get out my catheter, and from night one, didn't have any incontinence issues. Today, my every function that men are worried about when it comes to getting their prostate removed is intact for me. And it's God's grace. I found the right surgeon, and it's like it never happened. So,
well, thank you for sharing that, and just the emotional side of it, and kind of the faith-based side of it. So thank you for sharing that. Let's talk about your wife, because I know she's been a big supporter and been there with you this whole time.
Yeah. So we've kind of been through the ringer over the last 4 years since 2020. My wife actually went into liver failure, and she went into hepatorenal syndrome, which is basically a 2% chance of living, and went through a lot of lot of prayers, had a lot of friends, praying for us. And we went down to Swedish. Just to give you a little background, my dad was a physician. My mom was a nurse as well. Obviously, my sister's a nurse. My brother's in psychology, so don't have a lot of conversations with him. He diagnoses the family all the time. And then I have a lot of cousins that are nurse anesthetists, and a number that I worked at KU. But having that happen back in 2020 and then being diagnosed in 2023 with prostate cancer, it's been a few years, but with a 2% chance of living, my wife she could walk into the room and you wouldn't even notice that she's sick. And that's why it's so important just to be nice to people, because you never know what somebody is dealing with. They can look completely healthy and be basically in their last months of life. So I think it's very important to understand that. And she was extremely, supportive during this process, and it was wonderful to have her there.
Dr. Parker, when you meet a patient, you don't know what they're going through too, and
No.
and we've had several patients come on that partners are dealing with cancer at the same time, and it's like life is so crazy. You've got so much going on before even a cancer diagnosis. It's like, what's that like when you meet somebody and then you start to kind of form that personal bond with them, and then you learn what's going on kind of behind the scenes and help them through the process.
That's the part of this that I actually enjoy the most, is getting to develop those relationships with patients. The decision making with prostate cancer is incredibly complicated. And choosing the right decision when you have, I know we've talked about this on the show before, with prostate cancer you have multiple treatment options which carry about the same probability of cure. And when you have these balanced treatment decisions, often the decision making has a lot more to do with them, right? A lot more to do with their personality, the things they're going through, what can they tolerate as a burden of their treatment. And that's actually what I enjoy about what I do, is getting to know people, understand what drives them, what motivates them, to help guide them towards that appropriate treatment.
Not just clinical, it's
Correct.
personal.
It's very personal.
Yeah. Well, we have more questions. If you have any questions and you are watching us live, you can use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. So, Dr. Parker, as we've discussed, Chris is a fire chief. There's well-established connections between being a firefighter and then having a higher risk of cancer. Firefighters, as we know, are exposed to a lot of harmful stuff.
Mm-hmm.
Does that higher risk also apply to prostate cancer?
That's a great question. There have been some studies looking at this. There is an association with a higher risk of prostate cancer among firefighters. Now, do we know exactly what the linkage is? No. It goes to the point that firefighters are exposed to so many things, it would be hard to put a finger on one specific substance or what, hazardous material that drives that risk. But we do know there is a higher risk.
So it's not a huge leap to make that this is something environmental,
Correct.
Possibly.
Potentially.
Yeah. Hasn't proved that yet. But Chris, the laws are different state by state, as we know. In Washington, prostate cancer is considered a work-related cancer if you are a firefighter. So what does that mean? And what does that mean for you?
It's actually considered a workplace cancer if you're below the age of 50. And I was diagnosed because my primary care missed it for a number of years when I was 52, I believe. So with the assistance of Dr. Parker and working with Laborers and Industry, which is our state workman's comp here in Washington, we were able to get it identified as a work-related cancer. So another blessing, for us there. I'd like to go back, I guess, with my experience with my wife. And again, my mom's name was Mary, and it was something that I don't consider to be coincidence. And I told Dr. Parker this story as well. But the first nurse she had down at Swedish Hospital in Seattle, Washington, we got there around midnight, 12:30, the day that she got sick, and it was very acute for her. But our first nurse was named Mary, and that was really emotional for me that day, and I knew everything was going to be okay. We got switched over to UW, University of Washington. Her first nurse there was named Mary as well. And then I remember waking up at KU, and for a very brief period of time, my nurse was Mary Ann, and a lot of things lining up there. So, going back to the workplace, I told my crew up here in Point Roberts about my diagnosis, and a number of them have gotten tested as well. And I had a 49-year-old member who got tested. He's a Vancouver firefighter in British Columbia, and his PSA was 20. And he had no symptoms, no signs either. And he went through talking with me, talking with his doctors. He just went through a prostatectomy, I believe, in February or March of this year, so a few months after I did mine, and is doing exceptionally well too. But it's about saving lives, and Dr. Parker is all about saving your life, helping give you the best direction possible. And his specialty and his expertise and his surgery skills obviously led me where I am today with no issues after the surgery. So, my belief, God gave me that direction and brought me down to KU and to meet Dr. Parker. So it's I'll send anybody to Dr. Parker from this point forwards and to KU. And I've had a number of discussions with people since then that have been diagnosed recently, and just trying to help them and let them know my path that I took as well.
Can't get any better than that on a Monday morning.
No.
Right? That's a pretty good way to go. Okay, so I hear Chris talking about how he's reaching out to people. He goes through this experience, and then he's able to kind of advocate and talk more about prostate cancer openly with guys, and especially big, tough firefighters. Is there still a stigma with prostate health in general? I mean, are we not able to get past that? Can't we just talk about it?
I think there is still a stigma.
Okay.
Also, men just don't talk as much, I think, about their health as they should. We don't communicate well with each other about what we're going through, towards the point that Chris made earlier. You never know what somebody's going through, right? And we, unfortunately, are our own worst enemies as guys. We don't talk a lot about things. And so I wouldn't necessarily say as much of a stigma so much as it is just people aren't willing to share.
The communication issue.
Correct.
Yeah. All right. So have you started a support group, Chris?
I have, yeah. So doing that in my community, just in general, I've reached out to people, wanting to establish those connections to help people understand that regardless of what they're going through, what medical condition or any condition that they would just like to come and talk about, the fire station is open, and we can all get together and know that we're supported, that we're not alone in this fight. And if that's family that's gone through and you just want to talk about being a supporter for that family, because the family's a patient too, right? Whether you're going through what my wife went through, supporting her through her liver failure, supporting myself through my cancer with her doing that for me, there's a lot of stress and there's a lot of emotions involved. And I think it's important to help people understand that they don't have to feel like this needs to be a secret, that they can openly talk to people that are experiencing some of the same things, and know that they're someone special, and that they need, the support that anybody else would have as well.
Chris, tell us about your Welcome Home initiative.
So my Welcome Home initiative, we have a community paramedic program here in Point Roberts, and it's unlike other places. A lot of community paramedic programs deal with people that may be addicted to drugs or have high mental disabilities. And, my community average age is around 60. So we have a lot of people, it's about an hour to the hospital from where we're at. And that's on a good day and good borders. But if you get stuck in the border, it could be 3-4 hours trying to get down to the hospital. So the Welcome Home program for us is our community outreach and support. And our firefighters go out on a weekly basis into the community to see those that may be homebound or that just want to be checked in on, and have a conversation because maybe they don't have family available. rightly to them. And we also go down to the hospital once we transport people from Point Roberts. We will now go pick our residents up and bring them home. So they're a little bit more comfortable. They don't have to worry about a ride home or trying to get a friend to bring them back from the hospital. But, the fire department at Point Roberts will provide that for them. So it's a huge. I'm all about community, and it was a huge step for us, and it's been incredible so far.
See, that's why you got to get guys like Chris back to work, because look at all the stuff they're doing.
I know, that's absolutely amazing.
What questions, before we get to questions from our community, but what questions should men be asking their doctors?
I think kind of going back to the fact that prostate cancer is such a spectrum disease, and there's a lot of options and things that men can choose from. I think making sure that their physician, whoever's treating them, has access to all those options is probably the most important thing. So the first step, I think, is informing yourself, going to websites and places, academic websites, where you can find out more about what should be available to you as far as a treatment option, and then asking, are those things available to me? I think that's probably the most important step.
Let's get to some questions from our viewers this morning. And Jeremy has a good one. If you're done having kids or have had a vasectomy, is there much drawback to having your prostate removed? He says, I'm realizing this morning that I don't even really know what the prostate actually does.
That's a great question. So first off, the prostate's a reproductive organ. So it is involved in making the fluid that nourishes sperm. So that's its sole job in life, is reproduction. Unfortunately, towards your question, the prostate lives at the intersection of sexual health and urinary control. And so removing a prostate does expose men to a risk of incontinence and erectile dysfunction. And so without a diagnosis, those risks are too great to expose yourself to.
Makes sense. Stu wants to know, what does Chris's follow-up care look like?
So it's PSAs. I mean, after the initial recovery, right? Once we're sure that from a functional standpoint, Chris is where he wants to be, urinary-wise, sexual function-wise, then it's all about cancer follow-up, which is PSA-based. We monitor PSAs on a regular basis, typically about every 3 months for a year, and then every 6 months for a year, and then yearly from then on out. And that's how we know if the cancer is gone, in remission, or whether or not it's coming back.
Chris, a question for you. Amy wants to know what firefighters can do to help reduce their cancer risk.
I think the industry is moving towards that as well, but making sure that we shower after any type of structure fire, because the amount of carcinogens that we're exposed to, they soak through our skin. Sometimes we breathe those in between the time that we're wearing our SCBAs, or self-contained breathing apparatus. But it's really about the skin, the absorption through the skin, protecting our respiratory tract, and making sure that we shower after every structure fire, car fire, dumpster fire. It really doesn't matter. And then staying out of our bunker gear. The current bunker gear that we have is actually has filaments of PFAS, so PFAS, PFOS is what we call them, and those are cancer-causing forever chemicals, and you'd be surprised that they're actually in our firefighter bunker gear, and it's to help make it water repellent, and they're looking at bunker gear now that's going to be PFAS, PFOS free. They're looking at more dual-purpose gear as well. That'll be safer for us. But, not wearing just shorts underneath your bunker gear, but wearing sweats, keeping your pants on, as firefighters, keeping that so our skin's not in direct contact with our bunker gear. All of that can really help.
Last community question. What's your PSA now, Chris?
If I say it correctly, it's 0.1. Is that correct? Or 0.01, 0.1? It was 0.4. Yeah, 0.01. So it was 0.04 right after my first PSA. It actually climbed to 0.06, and I emailed Dr. Parker about that. And sometimes that can be a normal value. We were still really early after the surgery. I just went to Portugal, Spain, and France. Actually, it was on a Christian tour. I went to some big Christian sites over there, Fatima and Lourdes, and did that, and came back, and it was 0.01 on my test after I came back from my tour over in Portugal, France, and Spain in September. So again, graces to Dr. Parker, to anyone that's going through any type of cancers, and belief is a big belief of curing is a big pathway for us. And I've just been graced at this point. And again, it's because, Dr. Parker has been very supportive during this process. We'll be friends until we're both gone at this point, and I'll always direct people towards KU Medical Center. It was a tremendous experience.
Chris, thank you so much for sharing your story. And I think I speak for Dr. Parker and all of us here, just, that we're thinking of you, your wife, and we just want to hear good things moving forward. So thank you so much.
Thank you so much.
Dr. Parker, what's the big takeaway from Chris's story? And why is every patient that comes on is like your new best friend? Seriously.
I have a lot of best friends these days.
You do have a lot of good best friends. So, but when you hear Chris talk, what do you really want people to hear?
I think it goes back to kind of early on in his story. It's about taking charge of your health care, being your own best advocate. I think that's the most important thing to take from this. Certainly, Chris's positive attitude and the way he approaches his healthcare has been incredibly refreshing and amazing. I greatly enjoy our friendship, but I do think it's that self-advocacy that's so important. Good to have you back. Good to see you. Thanks so much. All right, thanks to both of our guests and to our viewers today. On a different note, thank you to the Kansas City Current for just really a thrilling season of soccer. The Current lost their semifinal match against Orlando this past weekend. But this season, the Current scored more goals than any other team. The health system has been the proud club's official healthcare provider this year. And we've seen a lot of teal in the halls and lobbies and clinics. It's just been so great to see all the support around women's soccer. So good luck to them next year. And again, thanks to our viewers for being with us. We'll see you back here tomorrow. Coming up tomorrow on the Morning Medical Update, a cancer diagnosis helps bring focus to what's truly important. For Jenny Nelson, it was the love of her life. I'm Jessica Lovell on the next Morning Medical Update, living and thriving with stage 4 breast cancer. See the vow renewal ceremony that made Jenny feel like royalty and the community of supporters letting her know she is loved. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stein's podcast. Now everywhere podcasts are available.